Thank you.
Cool. So hi guys, welcome to the Med Crash Course series. So tonight we will be doing a finals crash course on neurology. So it'll be part 1 and it'll be done by Dr. Andrew Hugh. Just to point out, our email is at the bottom left corner if you want to email any questions later on that you don't think of during the session, but please do feel free to put your questions in the chat and I will relay them to Andrew if you can't see the chat. And in the top right corner is a QR code for our Instagram page. So if you're not following it, please do follow and you'll see updates on when we post all our videos on YouTube as well. Cool. So if you go on to the next slide.
Yeah.
So this is a QR code for VBox, which we'll be using for our polls. So I'll post a link in the chat as well. So please do join, and it's completely anonymous as well, so please do try and answer. So I'll give you a minute to just join.
Right, I'm starting the session as well.
Yep, go for it. Cool, I think everyone's joined, so I think I'll just hand over to Andrew now.
Sure, okay, thank you very much. And welcome again to everyone. I'm Andrew. I can't see myself on the camera, so I don't know if you can see me, but it's nice to be here again. I was here last year too. So we have a few SBA questions or single best answer questions aimed at a finals level. They cover a variety of high yield topics. There's more to come. This is just part 1. And the questions have been written by myself and my lovely colleagues, lovingly handcrafted. So let's start off with the first one. Okay. So I'll read the question out. I'll give everyone a bit of time to answer, and then we'll go through what answers you may or may not have chosen. So a 23-year-old woman attends the epilepsy clinic, requesting a change in her anti-epilepsy medication. Her seizures started several years ago, where her partner noted episodes of her staring into space and making lip-smacking movements, which could occur when she was awake or asleep. She was started on carbamazepine, but wishes to change medications as she has been experiencing severe dizziness, nausea, and vomiting whilst taking the medication. What medication, according to current guidelines, should be trialled next to manage this patient's epilepsy? And I'll give everyone a bit of time to answer. Okay, just a few more seconds. All right, let's stop the poll here. So we have half of C and half on D, which is interesting. So the correct answer in my books is D, actually, which is lamotrigine. So this is one of the questions I wrote, and in the real exam, I like to highlight or underline important bits of the questions because they're usually quite long-winded. So in this case, I've highlighted staring into space and making lip-smacking movements. That is pretty typical of temporal lobe seizures. It's an automatism, this gestural movement that's repeated over and over again. Other kind of temporal lobe epilepsy automatisms are like plucking or grabbing movements. I've sometimes heard patients like putting their hands in their pockets over and over again, or doing their zip and undoing it over and over again, or things like that. And that's pretty typical of the temporal lobe. So this is a focal seizure or a partial seizure, as it's called. The first line was carbamazepine, which the patient was trialed on. And the other first line is lamotrigine, according to current guidelines. Levetiracetam is being used more and more these days, but the current guidelines still say lamotrigine. Again, it depends on your local guidelines, but the national guidelines say it's still lamotrigine. Now, as for other types of focal or partial seizure, it depends where they come from as to the symptoms. So we talked a bit about temporal lobe. The frontal lobe tends to be associated with movement type stuff, sometimes head or leg movements, abnormal posturing, or the Jacksonian march and that kind of thing. Very briefly, the occipital lobe focal seizures usually vision things, and the parietal lobe seizures usually sensory things. Let's see here. So yes, this slide is taken from the International League Against Epilepsy. It's their classification of seizure types. So there's two main types, or two and a half, I guess. We have the focal onset, also called partial seizures, and then you have your generalized onset seizures too. And the difference is, of course, as with any seizure, it's abnormal electrical activity in a particular network of neurons. But in focal onset epilepsy, that network of neurons is confined to one lobe or one hemisphere. But in generalized onset seizures, that network of neurons encompasses both hemispheres. And that's why you get the difference in symptoms. In terms of the generalized onset seizures, we've got our GTCS, our generalized tonic-clonic seizures. And that's what, I guess, lay people think of seizures. But other generalized onset seizures are things like myoclonic jerks, absence seizures, and things like that. Okay, and before we move on to the next question, just very quickly, of course, for generalized seizures, the first line is still sodium valproate. But the only, I guess, point of contention is that in women of childbearing age, we tend not to use sodium valproate if we don't have to. The reason for that is because, of course, it's very teratogenic. And if women are started on sodium valproate, we need to make sure they're on appropriate contraception. And there's lots of legal frameworks about that. OK, so the next question now. Let me open the poll for everyone. So a 33-year-old female presents to the headache clinic with poorly controlled migraines. She's been experiencing worsening headaches, which have occurred daily for the past 3 months, and describes taking her as required cocodamol and zolmitriptan every day at maximum dose as her prescription allows. Lifestyle modification has not helped to relieve her headaches. What would be the most appropriate initial management for this patient's headache? And again, I'll give everyone a bit of time to answer this one. Okay, just a few more seconds. Okay, let's stop the poll here. So we've got a bit of a spread here. 2 on D and then some on A and C. So let's see, the correct answer is to stop cocodamol completely. I think the option changed here to stop cocodamol and triptan completely, but D would have been correct beforehand as well. So with this question, I've highlighted this daily use of an opioid medication and a triptan every day at the maximum dose. This is a very typical presentation for what we call medication overuse headache. I think the strict definition says that if you're using the simple analgesia more than 15 days out of every month and you're still getting very bad headaches, that would classify as medication overuse. But it tends to occur especially with the opioid medication and the triptan medication too. Some guidelines say that we should stop cocodamol and triptan abruptly and let the patient ride out any withdrawal symptoms. But some newer guidelines also say that we should wean off cocodamol or any opioid medication slowly because we want to reduce withdrawal effects. Now, medication overuse headache is pretty difficult to manage in real life, at least in my opinion, as someone working in general practice. That's because patients are often very dependent on this analgesia to control their headache, and it's like a crutch. So if you tell them to suddenly stop taking their analgesia, they will be very reluctant to do so because they feel that their headaches will suddenly get worse again. And I mean, they might be right in the short term, but sometimes headaches do get worse before they get better. And sometimes they might experience some withdrawal symptoms, things like nausea and vomiting, restlessness or sleep disturbances. But ultimately, we would have to wean down the analgesia. Now, CT head, usually, at least in primary care, we don't request a CT head for headache. We request an MRI head, but let's say the benefit of an MRI head in medication overuse headache is limited. And trialing another triptan would be less ideal in this case because, again, the history is pointing towards medication overuse. It's likely that switching the triptan would not change the actual headaches themselves, and they would continue to get worse and worse. Medication overuse headaches are actually more common than you think. I believe the latest stats say 1 in 50. So they're definitely things that you will see. Yes, I made this slide ages ago. So the way I like to think about headaches is to think about them in terms of if they're primary or if they're secondary headaches. So secondary to another underlying disease process. At least in terms of SBAs, the primary headaches tend to focus on tension type headaches, which are the tight band associated with stuff like stress, sleep problems, or caffeine maybe. Then we've got our migraine headaches, at least in single best answers. They tend to be unilateral throbbing headaches, where patients often have to go into a dark room and close their eyes in order for the headache to go away. They tend to have photo and phonophobia as well. And then we have our cluster headaches, which tend to be on one side again. They are, of course, cluster in nature. They tend to be focused around one eye with a red eye, rhinorrhea, lacrimation, and patients tend to be very restless in the description of these questions. They're walking around, pacing because they're in so much pain. And of course, the secondary headaches, there's a variety of causes, too many to talk about in any great detail in this session. Use the surgical sieve, to be honest, to identify any secondary headache. Now, there are a few that you will be expected to pick up on. These are the ones in red. They're the emergent blackout. Subarachnoid hemorrhage is, of course, our thunderclap headache. Worst ever headache, like being hit in the back of the head, rising to maximal intensity in a matter of seconds. The meningoencephalitis, so they'll have meningism, you know, your neck stiffness, your pyrexia, your photophobia, and your stroke or TIA. Of course, think of your acute focal neurological deficit, maybe your fast type symptoms and things like that as well. Okay. So we have our next one. Now let me open up the poll again. So A 19-year-old female university student, Becky, is brought into A&E. She has a 7-hour history of headache, photophobia, and neck stiffness. She also has a fever and developed a non-blanching rash on her torso. Meningitis is suspected. Which organism is most likely to cause the patient's symptoms? Okay, just a few more seconds then. Okay, let's stop the poll there. The majority have said B and some C. And the correct answer is, in this case, B, Neisseria meningitidis. Now, this is a very typical history for what we call meningococcal meningitis. We have the meningism, which I guess I talked a bit about previously, so maybe I've given the game away a bit. The non-blanching rash is very pathognomic for meningococcal meningitis caused by Neisseria meningitidis. In most adults, the most common bacterial causes of meningitis are Neisseria meningitidis and Streptococcus pneumoniae, and of course the latter produces the pneumococcal meningitis. In single best answer questions, in the young and old, always consider Listeria as a cause of meningitis, and that's important because it alters what antibiotic therapy we give to someone. And in neonates and the very young, we get the weird and wonderful causes, things like group B Streptococcus or E. coli and things like that too. So this is a nice table, actually, not mine, but very nice. In terms of meningitis, let's see, this slide is perhaps slightly outdated in the treatment. More recent guidelines suggest the 3rd generation cephalosporin IV in all cases of meningitis. I think cefotaxime is the one that they currently use, but ceftriaxone can be used. If we suspect Listeria, so in the young and old, add in IV ampicillin or more recently amoxicillin, I think in the more recent guidelines. And for meningococcal meningitis, if you have a GP presentation of meningococcal meningitis, we can give IM benzyl penicillin as long as it doesn't delay their transfer to hospital. So all patients with suspected meningitis need to be sent straight to hospital by ambulance because it's an emergency. And we can see here IV dexamethasone. So we can give dexamethasone to patients with meningitis to reduce the risk of neurological sequelae of this disease, but we don't give dexamethasone in meningococcal meningitis, and we also don't give dexamethasone if someone is frankly septic as well. Of course, the supportive management like oxygen, fluids, ITU support if necessary. But obviously, probably more common, we have viral meningitis as opposed to bacterial meningitis. And the way that we differentiate the two is by lumbar puncture. And that table is very classic. So always think about the glucose, the protein, and what type of white cells you see. There's also the fungal and TB, but I'm sure everyone knows this table very well by now. So with viral meningitis, the most common cause these days are the enteroviruses. We tend to get sometimes herpes simplex virus meningitis, where we give IV acyclovir, but otherwise viral meningitis is usually self-limiting and the management is therefore supportive. However, if there's any suspicion of bacterial meningitis at all, you give antibiotics, and that's how it should be in the single best answer questions as well. Okay, so encephalitis is something else that can happen. That's a really nice picture. It's of course a T2 weighted coronal MRI showing enhancement or at least brightness of the temporal lobes and the hippocampal formations. If you see any picture like that, it's HSV encephalitis, which typically affects the temporal lobes. With encephalitis, it's inflammation of the brain tissue itself, so expect to see things like confusion or disorientation or seizures, changes in behavior or dysphasia, and then you might get localizing symptoms too, depending on where the inflammation is, maybe things like muscle weakness. And we have brain abscess as well. So brain abscess, when you see ring enhancing lesion on single best answer questions, one of the things that you must consider is brain abscess. As the slide says, the common organisms are bacteria or fungi. Brain abscesses might be caused by adjacent infection, your sinusitis, your mastoiditis, your otitis. But always think about brain abscesses in things like endocarditis and the immunosuppressed, where they can get abscesses in all sorts of weird and wonderful places. With brain abscess, expect to see your dull, persistent headache, your signs of raised ICP, and your fever with your swinging pyrexia, as well as focal neurology, which might occur due to the raised ICP or because of localizing symptoms too. The management of brain abscess, as this slide says as well, antibiotics, of course, but also surgical management might be indicated, a craniotomy, where we need to at least drain or debride the abscess depending upon the involvement, and maybe giving dexamethasone if there's lots of mass effect and signs of raised intracranial pressure too. Good, so that brings us on to the next question. Let me open the poll here. So we have a 24-year-old man, Ruben, got into a brawl one afternoon after his team lost a rugby match. He feels unconscious shortly after, he falls unconscious shortly after an unwitnessed injury, but regained consciousness after a short while. Later on during the evening, he developed a headache and started vomiting repeatedly. He then fell unconscious and started shaking. His partner called an ambulance in a panic. What is the most likely diagnosis? Okay, we'll give it a few more seconds. All right, let's stop the poll there. Okay, so we have the majority on E and some on C. Now the answer is E. So this is an extradural hemorrhage, or what's sometimes called an epidural hemorrhage. I would say this is a very typical history with head trauma. There's what we call a lucid interval, where someone has regained consciousness, and then a sudden deterioration in their GCS. The falling unconscious after the head injury is a red flag sign, which obviously means that there could be a serious injury here. So we have this nice image, actually. It's a CT of the head. It shows on the right side a frontotemporal epidural hematoma. It has a very nice biconvex shape which is because the collection of blood is contained within the suture lines of the skull, as opposed to subdural hematomas, for example, which are much more crescenteric in shape. However, usually our epidural or extradural hematomas, especially in single best answer questions, tend to be secondary to fractures of the pterion, which is the so-called weakest point of the skull. It's where I think it's the frontal, parietal, temporal, and sphenoid bones joined together. And if you fracture the pterion, you rupture the underlying middle meningeal artery, which can cause that collection of blood and the extradural hematoma. As the slide says here, CT head is the gold standard investigation for extradural hematoma and may also reveal other injuries. In terms of the management, the A to E approach is what you should say if you have your vivas and your OSCEs. In any unwell patient, in order to stabilize them, always approach it in an A to E way. Other considerations are, of course, if patients develop a seizure due to the pressure on the brain and mass effect, we might need to use anticonvulsants. If any patients are on blood thinners, anticoagulants, we need to reverse that, like reversal of warfarin. But the definitive management of these patients is to, I guess, reduce mass effect and maybe evacuate the hematoma. But this depends on things like how big the hematoma is, where it is, the amount of mass effect that's present, the age of the patient, and the comorbidities too. In some cases, if the hematoma is very small and not causing any mass effect, we might be able to get away with conservative management. However, usually there's a degree of craniotomy involved. That might be a burr hole craniotomy in order to evacuate the hematoma. But in very severe cases, we might have to do an emergency decompressive craniotomy, opening the skull up to relieve the pressure very quickly and get good access to evacuate any blood and maybe even ligate any bleeding vessels that are there. Okay. So next question, let me open up the poll for this one. So a woman phones her GP wanting advice about her 45-year-old husband who's refused to attend. Over the last few months, he's become increasingly irritable and out of character. 2 weeks ago, he lost his job for repeatedly missing deadlines. He's stopped taking care of himself, frequently wearing dirty clothes or neglecting his personal hygiene. He's usually fit and well, and his mother died at an early age of dementia. What is the most likely underlying diagnosis? Okay, it seems people have answered quite quickly on this one, which is good, but I'll give it a few more seconds. Good, okay, let's stop the poll here. Nice and quick, everyone knows it. The answer is D, frontotemporal lobar degeneration. That's a mouthful. Sometimes I use frontotemporal lobar degeneration and frontotemporal dementia interchangeably, but if we're being very picky, frontotemporal lobar degeneration is the pathological process which causes frontotemporal dementia, but that's only if we're being picky. So that history was very typical of frontotemporal dementia, actually. There are a few things. One of them is that there was an early age of onset. 45 is very young to be getting dementia of any kind, really, but the age of onset in FTD is usually 45 to 65. There's this predominance of behavioral changes, such as inappropriate behavior, impulsive or compulsive behavior, maybe being unsympathetic or neglecting personal hygiene. And then finally, also there's that familial component of the disease as well. Now, actually, I've noticed this slide, not mine, says frontotemporal dementia in brackets Pick's disease. Now, that presentation I would call Pick's disease, Pick's disease is actually a particular type of frontotemporal dementia. Like the question, it's where there's a preponderance of behavioral symptoms. It's also known as behavioral variant frontotemporal dementia, or you might see it written as BVFTD. But there's other types of frontotemporal dementia too. For example, the primary progressive aphasias. You might have heard of things like semantic dementia. These type of dementias usually cause communication difficulties, and in terms of semantic dementia, there's a loss of understanding of what words really mean, the semantics behind them. And that obviously results in communication difficulties and patients being unable to speak and communicate properly. So language symptoms as well might also relate to frontotemporal dementia. Now, as we can see here, MRI is the gold standard of imaging, CT only if MRI unavailable. And what we're looking for on MRI is atrophy of the frontal and the temporal lobes. But in early cases of the disease, you might not see any changes yet. And so some single best answer questions like to talk about the PET scan or the FDG PET. That's a scan showing metabolic activity. And in an FDG PET, at least in single best answer questions, you expect to see hypometabolism or poor metabolism in the frontal and temporal lobes too. Now, in real life, just as a side note, frontotemporal dementia really does have a big effect on patients and their families. So if someone starts getting dementia at 45, they might have children and a family. So it's a very big effect on loads of people. It's a progressive disease, of course. It steadily progresses with the survival time, usually say 2 to 20 years. And there's not really much we can do, unfortunately. Symptom control is the main management. We talk about SSRIs. They can help to control impulsive behaviors. But unlike other kinds of dementia, we don't use things like acetylcholinesterase inhibitors, things that we might use for Alzheimer's, like galantamine or rivastigmine. And that's because frontotemporal dementia doesn't have any effect on the cholinergic system whatsoever. So these medications wouldn't do anything. This table is quite nice. It shows us other kinds of dementia. Just a quick speed through. In SBAs, dementia with Lewy bodies, visual hallucinations usually occur in the question, a later onset of Parkinsonism as well. In vascular dementia, the single best answer question would do their very best to try and describe a stepwise decline without actually saying the words stepwise decline. And usually there'll be a vascular path. They'll have all their risk factors, like being a smoker, having high blood pressure and the like. And they may have also had some kind of vascular disease or strokes in the past as well. And of course, we know about Alzheimer's disease. I think one of the other options in the question was Creutzfeldt-Jakob disease, or the BSE, the bovine spongiform encephalopathy. That usually has a very rapid progression of symptoms if it ever appears in your SBAs, and in the majority of cases is associated with myoclonus too. So that's just something to keep in mind. Okay, so the next one, let's open the poll up here. So we have a 65-year-old woman presents with vertigo and ataxia. Upon taking a further history, the patient reports having a central headache and problems swallowing. You perform a cranial nerve examination revealing unilateral meiosis and enophthalmos diplopia and a hemifacial loss of pain and temperature sensation. A CT head is ordered, which confirms the diagnosis of ischemic stroke. Which vessel is the most likely location of the infarct based on the patient's symptoms and examination findings? Okay, I'll give it a few more seconds. Okay, let's stop it there. Oh my goodness, it's a very even spread on B, C, D, and E. I wrote this question, so it's going to be mean. The correct answer in this case is B, the posterior inferior cerebellar artery. Now, as I wrote the question, I'll highlight the important parts. So if I were to answer this question in the exam, I was underlining vertigo and ataxia. Sounds very cerebellar, perhaps. We have problem swallowing. We have this Horner syndrome type picture. And then we have hemifacial loss of pain and temperature sensation as well. That's a big mix of things, mainly brainstem, cranial nerve signs, as well as cerebellar signs. And yeah, stroke syndromes are classic single best answer territory. And in my opinion, if you see brainstem, cranial nerve, and cerebellar stuff wrapped up together, I always go for posterior inferior cerebellar artery. This particular syndrome is called the lateral medullary syndrome, or sometimes Wallenberg syndrome. And the way I like to think about it is consider the course of the posterior inferior cerebellar artery. I've got this nice picture which everyone is familiar with. So the posterior inferior cerebellar artery comes off the vertebral artery. It winds around the medulla, the lateral part of the medulla, hence the name lateral medullary syndrome. And then it travels under the inferior part of the cerebellum. So we have the posterior inferior cerebellar artery. So it travels around the medulla, traveling between the cranial nerves. So a stroke here is going to cause cranial nerve signs, and then it travels under the cerebellum. So a stroke there is going to cause cerebellar signs too. So that's the way I like to think about it. Now, you can technically get a similar syndrome of symptoms if you have thromboembolism of the vertebral artery too, but in SBAs, usually posterior inferior cerebellar is lateral medullary syndrome. In terms of the other ones that we've got, the anterior inferior cerebellar artery, usually associated with hearing loss, I've written here. And that's true because the AICA gives off this branch called the labyrinthine artery, or sometimes the internal auditory artery, that supplies the inner ear. So if you have any blockage of this vessel, expect to have hearing loss on the affected side. As for the other options, the middle cerebral artery, if that gets blocked, expect to see contralateral hemiparesis and sensory loss. That's what the lay person might think of as a stroke. The posterior cerebral artery is vision symptoms, cortical blindness, the homonymous hemianopia. And finally, the basilar artery, a stroke here causes the so-called locked-in syndrome. That's where patients are aware and they can perceive, but they can't communicate. Usually all four of their limbs are paralyzed. Sometimes they might retain their eye movements and blinking, but it sounds pretty horrible actually. So of course, the vasculature is something that we're all very used to. I guess this picture is something that we've seen a lot, but just remember, depending on where the arteries wind, what parts of the brain are affected, directly relating to what symptoms are caused. Yes, so there's some slides here about neurorehabilitation. This is less of a single best answer territory. It's more of a OSCE or Viva type territory. It really wasn't taught to me in med school a lot, so I think it's worth at least knowing about. Neurorehabilitation is referring to the, as it says, the complex medical process to assist recovery from neurological injury. So any kind of nervous system injury, things like stroke and spinal cord injury obviously apply here, but neurorehabilitation can also be used for things like multiple sclerosis or Guillain-Barré syndrome or even cerebral palsy. It's a good example of the multidisciplinary team, or holistic medicine, because it focuses on improving the well-being of patients, improving their independence, helping them to live the lives that they want and supporting them. So there's this very lovely set of animations here with lots of bubbles, which I enjoy very much, which shows us different members of the MDT which are involved in neurorehabilitation. Of course, it might be things like occupational therapy, which can provide home adaptations to improve a patient's independence at home. It might be physiotherapy to assist with mobility and strengthening joints and muscles. It could be things like speech and language therapy to assist with communication and swallowing difficulties. But we have, of course, our medical management, we have family support, psychological support. All of this stuff is really important. It's a great example of holistic medicine, as I've said before. And always when they ask you about the MDT, which they inevitably will do at some point, you can bring up all of these different services. Okay, so on to the next question then. This is the second to last question, by the way. So a 40-year-old woman has had worsening headaches over the past year. Headaches are worse on waking and better when she gets up out of bed. Examination is unremarkable. Family history reveals relatives with brain tumours and a cousin with neurofibromatosis type 2. You request head imaging for this patient, which I guess is this image in the bottom right. What is the likely diagnosis? Okay, so let's stop the poll now. Interesting. So we have a few on C and some on B. So the answer in this case is B, meningioma. So I'll go through this in a bit more detail. So neurofibromatosis type 2 is associated with bilateral vestibular schwannoma, I guess, is the first thing that people think about. But actually, other types of nervous system tumours can occur with neurofibromatosis type 2 as well. Things like meningioma, also things like ependymoma, which is a tumour of the cells that line the CSF spaces. Neurofibromatosis type 1 is also associated with lots of tumour types as well, as an aside. This image is really typical of meningioma. It's an MRI head, of course. There's a box around the tumour, which makes it a lot easier. We can see this is a tumour adherent to the meninges, the lining. We can also see a somewhat convincing dural tail on this image, which is quite nice. That's usually what you see in a meningioma, of course. I think sometimes if we're being very niche, spindle cells and psammoma bodies they talk about in meningioma too. I would say if this question had a patient with hearing loss, I would say vestibular schwannoma, but in this case, especially with the image, it's meningioma. So I'll talk a bit about the other options, just so we're clear. Glioblastoma, which is also called glioblastoma multiforme, is quite a common brain tumour in adulthood. It's a primary brain tumour. It might arise de novo or secondary to a low-grade glioma or something like that. Sometimes it's ring enhancing on CT. So again, ring enhancing doesn't have to be a brain abscess, so just be careful about that. vestibular schwannoma or the acoustic neuroma, gradual hearing loss on single best answer questions, can be unilateral. In the case of NF2, neurofibromatosis type 2, it could be unilateral or bilateral. You might get symptoms like fullness in the ears, dizziness or imbalance, tinnitus, and eventually as the tumor gets big enough and presses on the adjacent facial nerve, you get facial symptoms like numbness and weakness and things. Craniopharyngioma and medulloblastoma, the last two are tumors of childhood. Craniopharyngioma in single best answer questions, they love talking about its visual field defect, which is of course bitemporal inferior quadrantenopia. And medulloblastoma, I would say the only thing that they like to bring up in single best answer questions is it's a childhood tumor, of course, and it metastasizes throughout the central nervous system quite well. The reason for that is it gets into the cerebrospinal fluid, so it has access to the whole of the central nervous system. So the general approach to intracranial mass, as this says, we're talking about tumors mainly. And again, the way I like to think about this, kind of like headaches in a weird way, primary or secondary. So secondary, we're talking about metastases, and that's pretty common for metastases to the brain, perhaps more common than primary brain tumours. But primary brain tumours and secondary brain tumours produce similar symptoms. Your symptoms of raised intracranial pressure, of course, your headache progressively worsening, maybe worse in the morning or when getting up out of bed, your nausea and vomiting, your visual changes, and your focal neurology, depending on where the tumour is. So we can think about the symptoms depending on where the tumour is, of course, kind of like with most things, the occipital lobe, vision changes, for example, the frontal lobe, movement changes, the cerebellum, you'll have things like ataxia. So as for the treatment here, the MDT is what you should say. So deciding which treatment is needed depends on the MDT. They all get together and decide. It's usually a mix of surgical intervention, depending on the location of the tumor, but also the patient's age and comorbidities. Sometimes they just biopsy the tumor. Sometimes they intend to remove it entirely or only part of it in order to reduce mass effect, for example. And that can come in combination with radiotherapy and adjuvant chemotherapy too. There's also the option of palliative care. So symptom control is important in all patients. If we prioritize symptom control, then an early referral to palliative care is essential. So in general, the types of tumor, I've kind of covered these a bit already, but just to reiterate here, in adults, generally tumors are supratentorial, so above the cerebellar tentorium. In children, usually infratentorial as a rule of thumb. I'd say the only exception is the craniopharyngioma, which is by definition supratentorial. The most common tumor of childhood is the pilocytic astrocytoma, but then you get your medulloblastoma as well with its metastases. We have in adults, we have glioblastoma multiforme is the most common one, followed by meningioma. And meningioma, as it says here, is also associated with pregnancy in single best answer questions. So they can increase in size during pregnancy and start to produce symptoms. The reason is some meningiomas have progesterone receptors for some reason. So in pregnancy and pregnancy states, that can cause the tumor to be stimulated and increase in size. So it reveals itself if it was previously hiding away. And here is our final question of the day. So let's open the poll. So a 29-year-old gentleman is admitted to the emergency department after suffering a stab injury to the back of the neck. He's clinically stable but cannot move his left arm and leg. You decide to perform a complete neurological examination the results of which are as follows. So left-sided hemiparesis, number 1. Number 2, loss of proprioception and vibration sensation in the left lower and left upper limbs. And number 3, right-sided loss of pain and temperature sensation at the level of the C8 dermatome and below. An MRI scan is ordered, revealing a lesion of the spinal cord. Based on the clinical history and examination, what is the most likely location of the lesion? So I think I've saved the best till last here, but I'll give everyone some time to answer. Okay, just a few more seconds. Okay, right, let's stop the poll now. Good, so we have some C's and some B's. Now, this question is intentionally very mean, and I know that because I wrote it. The correct answer is B. So what I've highlighted is he can't move his left arm and leg, but what we need to focus on is this box of the neurological examination findings. So we have spastic paresis on one side. On the same side, we have loss of proprioception and vibration sensation. And then on the opposite side, we have loss of pain and temperature sensation. That should make you think of Brown-Séquard syndrome. It's the classic description of Brown-Séquard syndrome, and not just because I like saying the word classic, it's actually called classic Brown-Séquard syndrome. So classic Brown-Séquard syndrome, we have ipsilateral hemiparesis and ipsilateral loss of proprioception and vibration, and a contralateral loss of pain and temperature. That means it's left-sided, and we can see that the pain and temperature sensation is at the level of the C8 dermatome and below. Now, in Brown-Séquard syndrome, you lose pain and temperature sensation 1 to 2 spinal levels below where the level of the lesion is. So that means it's left-sided C5, C6 hemisection. And I'll try and explain this because it is quite complicated. So remember, there's the 3 main examination findings that we have. Number 1, if we have a hemisection of the spinal cord, we damage the corticospinal tract on that side. That obviously is part of the motor pathway. So we get an upper motor neuron lesion, so spastic paresis on the ipsilateral side. Number 2, we damage the dorsal column, which is responsible for proprioception and vibration sensation. So therefore we get a loss of proprioception and vibration sensation on the affected side. And number 3, we damage the spinothalamic tract. Now this is where it gets confusing, because if we remember how the pain and temperature information reaches the brain from the peripheries, we have our primary nerve fibers that travel from the peripheries into the spinal cord. When they enter the spinal cord, they go up 1 to 2 spinal levels. then they synapse on second-order interneurons. The second-order interneurons decussate, they cross the spinal cord to the opposite side, and then they travel up to the brainstem as the spinothalamic tract. That means that if you damage the spinothalamic tract, you get contralateral loss of pain and temperature because of the decussation, and as the primary nerve fibers travel 1 to 2 spaces up, you lose the pain and temperature sensation 1 to 2 levels below. So that is a very, I guess, complicated explanation for the constellation of symptoms you get. Now we have here the incomplete lesions of the spinal cord diagram, which is royalty-free, it's copyright-free, so it's nice. Brown-Séquard syndrome we can see here, damaging the corticospinal tract and the spinothalamic tract and the dorsal column. The other ones that they like to talk about are syringomyelia in SBAs. That's caused by a syrinx or a fluid-filled cavity in the central canal of the spinal cord. Usually this occurs in the cervical spine. So we'll damage the fibers immediately around the central canal of the spinal cord. Those are the decussating fibers, which form the spinothalamic tracts. Therefore, we lose the pain and temperature sensation. And usually it's like a cape-like distribution, they say, which just means the shoulders, the back, and maybe the upper limbs as well. And also the syrinx pushes on the ventral horns, which are also adjacent to the central canal, and that causes usually loss of the intrinsic muscles of the hand, since it's in the cervical region. Sometimes it can affect the whole of the upper limbs or the shoulders as well if it's very severe. But there's normal proprioception and vibration because the dorsal columns aren't affected by this. I think the other main one that they talk about, which isn't really an injury, like a traumatic injury per se, is subacute combined degeneration of the cord. That's usually caused by B12 or sometimes vitamin E deficiency. I've seen it in SBAs where they start folate replacement, where there's an underlying B12 deficiency, and then that precipitates subacute combined degeneration of the cord. Now remember, it's called combined degeneration because it's a combination of the dorsal column and the lateral column. So if we go back to this previous slide here, if we damage the dorsal columns, we lose proprioception and vibration sensation bilaterally. And if we damage the lateral column, we'll damage the corticospinal tracts. So again, we get spastic paresis bilaterally, and the other part of the lateral tracts right on the very edge of the spinal cord is the spinocerebellar tract. So you'll get cerebellar symptoms like ataxia too. There's some other ones here. Anterior cord syndrome, or Beck's, that's quite rare, usually caused by ischemia of the anterior spinal artery. Usually you get paralysis with loss of pain and temperature, because again, you're affecting not the dorsal columns, everything but the dorsal columns, essentially. And central cord syndrome is usually caused by trauma or crush. It causes motor impairment, as you can see, you're affecting the ventral horns, sensory impairment below the level of the lesion, and autonomic dysfunction too. Okay. And that pretty much wraps it up, actually. I'd say we've done that in quite a timely manner. There was a mix of quite difficult questions in there. I think you guys did quite well. I've got the QR code for feedback, which I would greatly appreciate because, of course, we'll ramp up for part 2 and do some more questions. And I can't see the chat, but if we have any questions, please let me know.
There hasn't been any questions yet, but I have posted the link for the feedback form in the chat as well.
Fantastic. Yeah, we made very good time today. I'm very pleased, and you guys did very well. The questions that I wrote are very difficult intentionally. They're designed to get you to think, but they do cover some high yield topics. So it's a very good set of revision questions, I would say, and more to come.